Hello, friends. Today I'll be discussing a crucial aspect of septic shock management, that is vasopressors. Let me share the slides over here. So all of us know this. If we get the initiation right, priming is very important when it comes to the vasopressors, and also the titration and weaning can be right. If we have all this timing, titration, and weaning right, we can save lots of life. So I'll walk you through the evidence, physiology, and practical pearls when it comes to the vasopressor management in the septic shock patient. So all of us face this questions: when exactly do I start vasopressors? Which one? How fast to titrate? Should I wait for fluid first? Remember, time to vasopressor is time to life. These are not just academic doubts; they directly affect our survival of our patients. And today we'll try to build a clarity: when to start, how to start, and which one to start it. So if you look into this, septic shock is not just a low blood pressure; it's a massive vasodilatation which occurs driven by the nitric oxide overproduction, and also there's a relative vasopressin deficiency that develops within hours of the onset of the sepsis, and the profound hypovolemia due to the capillary leak, which leads fluid from the vascular space into the interstitium, results in critical depletion of intravascular volume, and that is again a major cause of the hypotension which comes as also there's a myocardial depression, microcirculatory dysfunction. Our goal with the vasopressors is not only to raise the map but to restore organ perfusion by countering these mechanisms. This is why understanding this pathophysiology is quite crucial, and we aim to restore adequate perfusion with the initiation of vasopressors. So now, when to initiate vasopressor? What does evidence say? So, surviving sepsis guidelines 2021, they suggest to start vasopressor within 1 hour if the MAP is less than 65 millimeter of mercury despite initial fluid resuscitation. So, consider starting earlier, concurrently with the fluid if profound hypotension presence. And the trials such as Andromeda and Sensor trial highlight that earlier use improves shock control, reduces fluid overload, and speeds up recovery. So key point is don't wait full for the full 30 ml per kilogram bolus where the patient is crashing. Start early. And same was shown in the Andromeda trial, which showed a trend towards faster shock resolution and improved perfusion markers. And also the sensor proved the same thing, and which resulted in less of the fluid requirement and less incidence of the pulmonary edema in our patients. So now clinical decision when to start. So we all know surviving sepsis guidelines suggest when the MAP is less than 65 millimeter of mercury despite initial fluid bolus or the lactate is more than 2. In certain cases, a few studies says when it's more than 4, there's a mottling, pure capillary refill or ongoing shock despite of the fluids. We all have to start vasopressors as early as possible. And meta-analysis by the Austrian and Tuscan et al showed a delay beyond 3 to 4 hours worsens mortality. In short, fluid and vasopressor should go hand in hand in profound shock. Personalizing targets, map of more than or equal to 65 millimeter mercury is recommended for most of the patients, as suggested by the recommended by the surviving sepsis guideline. And this target represents the minimum perfusion pressure which is required to maintain adequate organ perfusion in most septic shock patients without significant comorbidities. So when we went through the different trials like sepsis which was done in 2014, which compared the map of 65 to 70 versus map of 80 to 85 millimeter mercury. And they did not show overall mortality benefit, but AKI was more in hypertensive group. So someone who was hypertensive and we were maintaining a blood pressure of 65 to 70, we had more incidence of acute kidney injury in the sepsis trial. 65 trial, which was done in 2020, it allowed the blood pressure of 60 to 65 permissive, and no harm was seen, possibly fewer adverse events because the less of the arrhythmogenic catecholamine induced effects of the vasopressors. Oppress trial, which has just come in 2025, and they compared the pressures of 65 to 70 versus 80 to 85, and higher mortality was found in high MAP group. So, over and all, in older patient with septic shock, targeting 65 to 70 safe and effective. Avoid higher MAPs. But in the comorbid patients who are the chronic hypertensive, or maybe the MAP target will vary and they might require vasopressor early. So this is what and when it comes to the lower map target, so this was seen considered in lower specific scenarios like young patients without comorbidities with normal autoregulation. They tend to tolerate hypotension pretty well. The risk of catecholamine toxicity in those patients is more, it leads to the digital ischemia and arrhythmias. In case of the pregnancy, maintain uteroplacental perfusion. So we might be okay with the lower targets, and of course the refractory shock patients we can accept. Lower map if the perfusion improves overall. So beyond numbers, what we look into is we don't treat blood pressure alone. We treat perfusion. So look at the dynamic clinical markers like capillary refill time, skin mottling, urine output, mentation. We can also go around the lab reports like serial lactates. We have to look into the lactate trends, the trends of the central venous oxygen saturation, atrial venous carbon dioxide gap. Also, we can look into the advanced tools like bedside Doppler, PPV, stroke volume variation, diastolic shock index. In fact, Andromeda shock trial showed CRR, that is capillary refill time guided resuscitation, was a good or better than lactate clearance, and bedside clinical signs do still matter. This is what it tells us. Predicting responsiveness of the vasopressor, so there are various ways of doing it. If we look into the diastolic shock index, and which is approximately more than 1.3, it predicts vasoplasia and the need of vasopressor early, as was demonstrated by the Oskian and Tuscan and colleagues. And the vascular occlusion test needs NIRS to assess the microvascular reactivity and detect impaired autoregulation. And the vascular occlusion test can also identify patients who may not respond adequately to standard vasopressor therapy. Capillary refill time, we all have seen, as was suggested by the Andromeda trial, it was as good as the lactate clearance, and it indicates a compromised, poor capillary time indicates a compromised peripheral perfusion and suggests a need for vasopressor support to restore adequate perfusion pressure. Always integrate vasopressor use with monitoring basics, BP and lactates, echo for preload and contractility, dynamic indices like SCV, PPV, or advanced devices whenever available. Never use vasopressors in isolation. Context is key. To now come up to the main question, we all know the answer is norepinephrine. So when the first line therapy, norepinephrine remains the gold standard. It's a potent alpha 1 with modest beta 1 activity and raising MAP with fewer arrhythmias when compared with the dopamine, as was shown by the SOAP trial. It was very superior to the noradrenaline, and this is why the dopamine has become absolute now. And practical dosing is simple, right, and to be titrated carefully while monitoring the perfusion. So if we take a standard concentration of 8 milligram of norepinephrine and 50 ml of saline, which is approximately 160 microgram per ml. So for 70 kilogram patient, zero point 0.1 microgram per kilogram per minute dose would be 7 microgram per minute. That would be approximately a rate of 2.6 ml per hour, and this is the easy calculation. So suppose if I had to start at 0.0 mics per kilogram per minute for 70 kilogram of patient, with that dilution, I'll be using 2.6 ml per hour. Now, this is the question, which is the second line. Again, the answer would be very easy. We all know the vasopressin is the drug of choice when it comes to the second line vasopressor in patient of the septic shock. And in septic shock, the rationale is in septic shock patient, vasopressin deficiency is common, and it targets the different receptors as well than catecholamines. And the fixed dose of zero point zero 0.03 units per minute is to be used and never to be titrated. So the trials like Venice showed real benefits, especially when the vasopressin was combined with the steroids. And same was also proven by the VAST trial, which suggested survival benefit in less severe shock patient. But when to add it? So consider when the noradrenaline dose is more than zero point 0.2 to zero point 0.3 mics per kilogram per minute, particularly beneficial in patients with right heart strain, renal dysfunction, and the respiratory acidosis. That is the time to use the second vasopressor and uh, add vasopressin. How about the additional vasopressor? So epinephrine is useful in refractory cases when our noradrenaline and vasopressin are not adequate enough to restore the MAP and restore the perfusion, but it causes arrhythmias and sometimes the lactate rise as well. Angiotensin 2, as shown in the ATHOS 3 trial, it rapidly restores the MAP, and it's catecholamine sparing, though it's a costly option. But dopamine is absolute now, as was seen in the SOAP 2 trial. it had higher mortality and more arrhythmias when compared to norepinephrine, and not recommended in septic shock as per the current guidelines. Methylene blue may be considered as a rescue agent in catecholamine refractory vasoplasia due to its nitric oxide scavenging properties. So when you talk of the Athos-3 trial, the trial proved angiotensin 2 works when it was done in around 164 patients with vasodilatory shock requiring high dose of vasopressors, and there was a comparison of angiotensin versus placebo, and the primary endpoint was mapped at around 3 hours. So what it demonstrated was in angiotensin 2 had approximately 70% response rate as compared to 23.5% with placebo for achieving MAP of more than 75 or more than 10 millimeter of mercury increase at 3 hours. And this is what led to FDA approval of angiotensin 2 for vasodilatory shock in 2017. So angiotensin 2 works through 81 receptors to cause direct vasoconstriction. A specific advantage is rapid onset, catecholamine sparing action, preserved in sepsis, and it also causes a renal protection. So clinical consideration is start at 20 nanogram per kilogram per minute. It's quite costly, and the risk is thromboembolism. We need to monitor closely, especially in the hypercoagulable states. Additional vasopressors options, we have seen this. We spoke, sorry for it. So yeah. Now, vasoplasia and the mechanism of targeted therapy. So we all know vasoplasia is a catecholamine-resistant dilatation due to excess nitric oxide and potassium channel activation, receptor desensitization. So methylene blue inhibits guanylate cyclase, reduces cyclic GMP, and restores the tone. So dose is approximately 1 to 2 milligram per kilogram and used in refractory shock when we have a patient with very high dose of noradrenaline. So peripheral versus central administration, we have to look into. So we all are aware of do not delay vasopressors waiting for the central line. Short-term peripheral use is safe if monitored well. Use always large veins like anticubital, and it can be safely used for 6 to 12 hours. But central line is mandatory. Go for it when for prolonged or high doses. An expert recommendation: do not delay vasopressor initiation while awaiting a central line access. Surviving sepsis guideline ICCM endorses safe peripheral initiation in resource constraints or the emergency settings. Management of refractory shock. So suppose we have a patient where we have started with the high dose norepinephrine, vasopressin has also been added to it, and we have achieved an adequate volume status. So we do a diagnostic workup in such cases with echocardiography to assess cardiac function, evaluate for ongoing sources or uncontrolled sepsis, and rule out adrenaline insufficiency, tamponade or abdominal compartment syndrome. Do focus, look for the IVC collapsibility, LVOT, VTI, and RV function. If all options are being done, then consider adding epinephrine or maybe the angiotensin 2 in the selected cases, and maybe the methylene blue when we have the vasoplasia and patient is not responding to the high dose. Steroids, we do need to add it. I'll come to the next slide when to add it. Usually we consider steroids when we start with the vasopressin and we add on the second vasopressor. Consider ECMO in selected patients where the myocardial dysfunction is a major problem rather than actually a septic shock. So steroids, when to add it, we all have seen approaches. Trial showed hydrocortisone and fluorocortisone showed mortality benefit in septic shock patients requiring vasopressors, and adrenaline trial showed hydrocortisone alone showed faster shock resolution but no mortality benefit. So indication, vasopressor dependent septic shock when noradrenaline is approximately more than 0.25 to 0.5 microgram per kilogram per minute. When we consider adding vasopressin, and these are the patients we should be consider adding steroids and continue until vasopressors are no longer needed. Then taper over few days to prevent rebound inflammation and hypotension. Vasopressor phenotyping, we all know not all shock are the same. Hyperdynamic, hypodynamic, mixed, cardiogenic, all need different vasopressors of choice. And this is the precision medicine of shock. Future research may even use genetics to guide the therapy. So type 1 may be hyperdynamic, where we have the high cardiac index and low SVR. Type 2 is hypodynamic, where we have low cardiac index and high SVR. Then followed by the mixed and the cardiogenic shock, where we have the low cardiac index and high blood pressure. So it's very emerging topic which is coming in, and we might have the precision vasopressor therapy depending on the phenotype of the shock. Now, the biggest dilemma is when to wean. I mean, which vasopressor to taper first. Evidence is conflicting. There have been a group which suppose norepinephrine first, discontinue norepinephrine first, and maintain vasopressin until hemodynamic stability. And there's a second group which says discontinue vasopressin first and maintain norepinephrine until patient is hemodynamically stable. So we had seen this in a conflictory uh, evidence, the first tapering strategy. So DOVSS trial, a randomized control trial, which was done by John et al. In 2018, conducted a prospective study and where the vasopressin was the first agent to be stopped early. And what it showed in the trial was stopped early due to significant findings. So the patient where the noradrenaline group was stopped first developed hypotension after first vasopressor trapping, approximately around 68.4% of the patient, versus 22.5% of the patient where the vasopressin was stopped first developed hypertension after first vasopressor tripping. So the physiological rationale of this is AVP has a longer effective half-life, around approximately 10 to 20 minutes when compared to the norepinephrine, which is 2 to 2.5 minutes, and potentially avoiding rebound hypertension. Norepinephrine generally considered easier to titrate when it comes to the vasopressin. But the con was it's a small study, single center, early termination may overestimate treatment effects, and vasopressin group had lower oxygenation status, higher mechanical ventilation requirements. So maybe those patients are more sick. Again, this is the evidence which supports the norepinephrine first strategy, and it was done by Yong et al. And a large retrospective cohort study. So it's a multi-center study examined over 2,000 patients of shock and approximately 961 with the septic shock, and with striking different results. So we have one group where the of the vasopressin where the incidence of hypotension was around 42% versus the noradrenaline group where the incidence of hypertension was 14%. So this favored to taper noradrenaline first, and additional clinical outcomes were in the vasopressin group for the long time to shock reversal, higher mortality and 28-day mortality, increased risk of hypertension. But the limitation was retrospective design with inherent bias, lack of protocolized weaning, significant baseline imbalances, and the vasopressin group had higher comorbidity index, though they had the patient with the prevalence of cancer, sepsis, diabetes mellitus, dialysis requirement, and the corticosteroids use. So as of now, directly contradictory finding in both the studies. DOBSS suggests tapering vasopressin first, which leads to the suggests tapering vasopressin first leads to lower hypertension rates, and Yong et al. Indicates tapering norepinephrine results in lower hypertension rates. So we have the additional supporting evidence for the norepinephrine. It was the Bauer et al. In 2010 and Amond et al. In 2017 also reported higher hypertension incidence when vasopressin was discontinued before norepinephrine retrospective analysis, and evidence showing no difference is et al. In 2018 found no significant difference in hypertension and incidence based on discontinuation, whether it was a vasopressin or the norepinephrine. So overall, we have a conflicting evidence, and the key pathophysiological consideration for the vasopressin is there is always a relative vasopressin deficiency, and particularly when the serum copeptin levels are low, it indicates unmasking of the relative deficiency in some patients. And also the vasopressor receptor dynamics, maybe the prolonged exposure to catecholamines may lead to adrenergic receptor downregulation and desensitization, potentially affecting vascular responsiveness during weaning. So co-founding factors are corticosteroid use, fluid bolus administration, baseline comorbidities, and the interaction between the corticosteroids and vasopressors also influence on vascular sensitivity and AVP receptor regulation. And this all may affect the rebound hypotension overall. So we have to look into clinical guidelines and the future direction. So as of now, which vasopressor to taper first, we don't have any clinical guidelines. So start weaning when the MAP is somewhere around less than 65. We have to individually assess the patient. We have to monitor the protocol and gradually taper your vasopressor rather than quickly. And eventually, the research points will be the standardized weaning protocols we have to look into, and we have to certify the key confounders like corticosteroid and maybe the severe cases. We might also find out the relevant biomarkers like copeptin. If low copeptin might tells us we may continue tapering noradrenaline first in certain cases. So start weaning MAP when the patient is stable, like blood pressure MAP is more than 65, lactates are clearing, basic condition is improving, and infection is under control. reduce norepinephrine solely, you can go with the norepinephrine first or the vasopressin first. Still, there are no suggestions by the guidelines and the evidence is heterogeneous, but go with the titrate based when it comes to the norepinephrine, and always watch for the rebound hypotension. Be aware in special populations like in heart failure, combine inotropes. In CKD, aim for the higher maps. Use vasopressin early. In neuro patients, higher maps, sometimes we might have to add the epinephrine as well, and tailor therapy to the underlying organ vulnerabilities as well. So, in practical assessment, initial assessment is maybe calculate the DSI, that is diastolic shock index, assess fluid status with the focus and IVC, check lactate, capillary refilling, and the mottling. We all know the first line vasopressor is norepinephrine. Titrate to maintain a blood pressure map is about 65 millimeter of mercury. To continue balanced fluid resuscitation. Add vasopressin when we have crossing the dose of norepinephrine by 0.25 to zero point 0.3 microgram per kilogram per minute, and consider hydrocortisone at the same moment. Also reassess for the source control and underlying causes. Look for the refractory shock. You might consider adding epinephrine, angiotensin 2, or maybe the methylene blue in certain cases. So the future is exciting. Pharmacogenomics, AI-driven titration, novel agents like selective V1 alpha agonist and biomarker guided resuscitation are coming in, and trials like HiMAP and EvoShock are ongoing, and the era of precision shock management is very near. So key takeaways: start norepinephrine within 1 hour if the map is less than 65. Target 65 millimeter of mercury, but individualize in certain cases, especially in the chronic hypertension and the CKD patient. Add vasopressin the moment you cross the norepinephrine by 0.25 microgram per kilogram. Consider using steroids at the same moment. Peripheral use is safe for approximately 6 hours. And remember, numbers don't matter. What matters is perfusion. Vasopressors are the bridge. We must guide wisely. Thank you very much. And these are the references which I use for my talk. Thank you.